You take a little pill every morning for your blood pressure. Your doctor started you on it years ago. The number on the cuff reads fine, so you've never thought twice about it. But if you're also more tired than you used to be, if the weight is settling around your middle no matter what you do, if a flight of stairs leaves you more winded than it should, there's a real chance that pill is part of the reason. And the cuff reading looks perfectly acceptable the entire time, which is exactly why nobody has connected the two. The pill is almost certainly one of a class of drugs called beta blockers. They've been handed out for high blood pressure for 50 years, and for one specific kind of patient, they are genuinely life-saving. But the science on using them for ordinary high blood pressure moved on a long time ago, and the prescription pad never got the memo. I'm Dr. John Myers, and on this channel I take the research that has changed and put it in plain language for people over 60, so you can walk into your next appointment knowing more than 12 rushed minutes will ever let your doctor explain. Now, before you decide this doesn't apply to you because your pressure reads fine, that acceptable number is the whole trap. It is the reason a pill can be working against the rest of your body while everyone keeps nodding at the cuff. By the end of this, you'll know 3 things. Whether your pill is one of the ones the guidelines quietly walked away from, the specific ways it can work against a body over 60, and the exact questions to bring to your doctor so this finally gets looked at, instead of renewed on autopilot for another 3 years. And look, this whole question, a medication that's supposed to be helping you while costing you something, it's exactly the kind of thing my patients bring to me all the time, about one part of their health after another. So I took everything I tell my own patients and put it into one simple plan for living longer, stronger, and healthier after 60. 28 of the things that actually change as you get older: your blood pressure, your blood sugar, your memory, your balance. And those are only some of them. Thousands of people are already using it to take back their health. It's already helped so many of them live their best life after 60. The link is on your screen right now, so go check it out at drjohnmyers.com. All right, back to that pill. Let me tell you what a beta blocker actually does inside you, because once you understand it, everything else today makes sense. Your heart muscle is covered in tiny receptors, little docking points called beta receptors. Adrenaline, the hormone your body releases when you climb a hill or get a jolt of stress, plugs into those docking points and tells your heart to beat faster and harder. A beta blocker settles onto those same receptors and keeps the adrenaline from reaching them. So your heart rate comes down. Each beat pushes with a little less force, and your blood pressure drops. That is the whole idea. Now here's where I want to be completely fair, because this part matters. For certain hearts, that calming effect is exactly what you want. If you have had a heart attack, if you are living with heart failure, if your heart slips into a dangerous rhythm, then slowing and steadying that heart genuinely saves lives, and the evidence for using a beta blocker there is rock solid. I would prescribe one for those patients without hesitating. So please do not hear me saying these are bad drugs. That is not what I am telling you. The problem is who else ended up on them and why they never got taken back off. For decades, beta blockers were a go-to for plain high blood pressure. You might know yours by its name: metoprolol, sold as Lopressor or Toprol; atenolol, sold as Tenormin; propranolol; bisoprolol. They are cheap, they are familiar, and doctors wrote them for blood pressure for 2 generations. Tens of millions of prescriptions a year. Then the research caught up with them, and it was not kind. In 2005, one of the largest blood pressure studies ever run was published in The Lancet. It was called the Ascot trial, and it followed more than 19,000 people with high blood pressure. Half were treated on a plan built around a beta blocker. The other half on a different plan, built around a calcium channel blocker, a drug called amlodipine that lowers pressure by relaxing the walls of your arteries instead of slowing your heart. The 2 groups were compared head-to-head for years. The trial was stopped early because the difference between the 2 groups had already become too clear to keep it running. The group that was not on the beta blocker had 23% fewer strokes, 16% fewer heart problems overall, 24% fewer deaths from heart disease, and about 1/3 fewer new cases of diabetes. Hold on to that last one. I am coming back to it because it is a bigger deal than it sounds. Those results were strong enough that in 2006, the national body in the United Kingdom that writes medical guidelines, an organization called NICE, formally moved beta blockers off the first choice list for uncomplicated high blood pressure. They did not ban them. They are still recommended for those heart conditions I mentioned, but for straightforward high pressure with nothing else going on, they stopped being a preferred pick. And now, almost 20 years later, that is still their position. Here in the States, though, millions of people are still on one as their main blood pressure drug. Usually because a doctor prescribed it a long time ago, it brought the number down, and nobody has revisited that choice since. There is no alarm that rings in your medicine cabinet when a guideline changes. The prescription just quietly renews itself year after year. So let me walk you through the specific ways this drug can work against a body over 60. There are several, and I want you to notice whether any of them sound like your last couple of years. The first one is the one I hear about most: tiredness, and a very particular kind of it. Remember what the drug does. It keeps your heart from speeding up. For a younger person at a desk, that ceiling is invisible because they rarely ask their heart for much. But you are not at a desk. You want to walk the block, carry the groceries in from the car, get up a flight of stairs without stopping halfway. Every one of those things asks your heart to speed up, and the beta blocker is holding it back. So you hit a wall sooner than you should. Your legs feel heavy. You are winded before you think you have any right to be. This does not happen to everyone, but for a lot of people, especially older folks who already have less in the tank to begin with, it is very real. A patient I will call Lorraine put it to me better than I could. And I want to be upfront that Lorraine is a blend of several people I have cared for, so no one is singled out. She was 72, and she told me she had stopped taking her evening walk. Her knees were fine. It was that, in her own words, she was running on half a tank all day, every day. She had been on atenolol for 3 years. Her old doctor had chalked the tiredness up to her age. Nobody had thought to look at her pill bottle. And here is the part that is almost cruel. The single best natural tool you have for lowering blood pressure is movement, walking, staying active. If the medication makes moving feel harder, you move less. And when you move less, your pressure drifts back up. So a pill meant to lower your pressure can make the very thing that lowers it naturally harder to do. If you started a blood pressure drug and your walks got shorter around the same time, that timing is worth a hard look. It is the first thing to write down. The second problem is metabolic, and this is where I need to be precise because most videos on this get it flat wrong. The older beta blockers, atenolol and metoprolol, the ones most people over 60 are taking, nudge your body in the wrong direction on blood sugar and cholesterol. They make your cells a little more resistant to insulin, which is the hormone that clears sugar out of your blood. They tend to push your triglycerides up and your HDL, the good cholesterol, down. Quietly, in the background, while your blood pressure number looks fine. This is not a small footnote. A large analysis in the American Journal of Cardiology back in 2007 pooled almost 95,000 patients and found that people on beta blockers had about a 22% higher risk of developing type 2 diabetes than people on other blood pressure drugs. Remember that third fewer new diabetes cases from the Ascot trial? Same finding, same direction, over and over. Now here is the nuance almost nobody bothers to tell you, and it is the reason I do not want you falling for the internet's blanket panic about this. Not all beta blockers do this. The newer ones, carvedilol, sold as Coreg, and nebivolol, are built differently. They also relax your blood vessels, and they are close to neutral on your metabolism. So if you happen to be on one of those, this particular worry mostly is not yours. This is really a story about the old workhorses, atenolol and metoprolol, which just happen to be exactly the ones most people over 60 were started on years ago. And a quick word about weight, because you may have heard these pills pack on the pounds. The honest number is a lot smaller than the scare stories. On average, it is a couple of pounds, mostly in the first few months, and again, mainly with the older drugs. It is real, it is just not dramatic. But if you are already fighting your blood sugar or your waistline, even a small shove in the wrong direction from a pill that is not even outperforming its alternatives is worth questioning. The third thing is less a side effect and more a blind spot, and honestly, it is the one that worries me the most. A beta blocker often does bring your blood pressure number down. Your cuff reads 128/78. Your doctor sees that, you see that, and everyone relaxes. The number looks handsome. But that number is only one window into your health, and it happens to be the one window this drug keeps looking good. Underneath an acceptable reading, if it is one of the older beta blockers, your insulin resistance may be creeping up, your cholesterol may be drifting, and your energy may be draining away, and not one of those shows up on the cuff. You can have a beautiful blood pressure and still be quietly sliding backward. A good number is not the same thing as the right medication. There is one more worth mentioning, and I am going to be careful here because the internet badly oversells it. Like most blood pressure medications, a beta blocker can leave you lightheaded when you stand up too quickly. That swimmy gray moment when you get out of a chair. In an older body, that unsteadiness is worth taking seriously because a bad fall can start a spiral that is hard to come back from. I will be straight with you that the evidence tying this specifically to beta blockers, more than to any other pressure drug, is genuinely mixed. But it is one more reason the newer classes are usually the ones we reach for first in seniors today. Before I show you what the evidence actually supports instead, and that is the part you came here for, do me one small favor, because it honestly shapes what I make next. If this channel has taught you something today, subscribe, tap the like button, and in the comments tell me two things: your age and the blood pressure medication you are currently on. Just the name off the bottle. I read them, and the pattern in those comments tells me exactly which topics to dig into next for you. All right, so what does the research actually favor instead? But before I give you a single alternative, I have to stop you, because this next part could genuinely protect your life. Do not stop a beta blocker on your own, ever. Not by skipping doses, not by cutting the pill in half because a video told you to. When you have been on one of these for a while, your body adjusts to it. If you pull it away all at once, your heart can rebound, your rate and your pressure can spike hard and fast, and in someone with an unhealthy heart, that can set off chest pain, a dangerous rhythm, even a heart attack. Coming off a beta blocker has to be done slowly, tapered down over several weeks, typically, with your doctor watching the whole way. What I am handing you today is information and the right questions to ask. It is not permission to open the cabinet and start making changes yourself. With that firmly said, here is what the research favors for a senior whose only real problem is high blood pressure. The first is that calcium channel blocker I mentioned, amlodipine. It lowers your pressure by relaxing the muscle in your artery walls, so the pipes open wider. It was the backbone of the winning side in the Ascot trial. It does not carry the same metabolic baggage as the old beta blockers, and it does not put a ceiling on your exercise the same way. For a lot of older adults with plain high pressure, it is simply a cleaner fit. The second group is a pair of closely related classes, ACE inhibitors and ARBs. These work on a hormone system that tightens your blood vessels and makes your body hold on to salt and water, and they gently switch that system down. Names like lisinopril and ramipril are ACE inhibitors. Losartan and olmesartan are ARBs. They protect your kidneys, they tend to do well in people who are also managing diabetes, and they are easy on your metabolism. One quirk worth knowing: ACE inhibitors give about 10 to 15% of people a nagging dry cough. Estimates vary, but it is common enough that you should know it going in. If that turns out to be you, an ARB does nearly the same job through nearly the same pathway without the cough. That is usually a simple switch. Now let me draw the line just as clearly in the other direction, because I do not want a single person walking away from a medication they truly need. If you are on a beta blocker because you have had a heart attack, because you have heart failure, because you have a rhythm problem like atrial fibrillation, or because you get angina, that is a different situation entirely, and the evidence for keeping you on it is strong. There is even newer research showing the post-heart attack benefit is clearest when the heart's pumping strength is reduced, so it is worth knowing exactly why you are on yours. The concern I have laid out today is aimed at one specific person, the senior whose only diagnosis is high blood pressure, nothing else, who was handed an older beta blocker years ago and never had it looked at again. If that is you, this is a conversation absolutely worth having. So here is exactly what to do with all of this. Not tonight, not in a panic. Calmly and in order. First, find out what you are actually taking. Go and read the bottle. Is it a beta blocker, one of the names that ends in those letters, OLOL, metoprolol, atenolol, bisoprolol, propranolol, carvedilol? And is it there purely for blood pressure or for one of those heart conditions? If you cannot say for certain why you are on it, that alone is worth a phone call. Second, write down 3 questions before your next appointment, because the visit is short and you will forget them in the moment. Question 1. Is my beta blocker here specifically for blood pressure, and does that still match the current guidelines? Question 2. Have we checked my blood sugar and my cholesterol lately, given what this drug can do to them? Question 3. Based on my whole picture, would I be a good candidate for switching to a calcium channel blocker or an ARB? Write those 3 down. Bring the paper with you. Third, ask for a medication review. If you have been on the same blood pressure pill for more than 2 or 3 years and nobody has re-examined it in all that time, you are completely within your rights to ask for a fresh look. A great many people are still taking a medication that was standard practice in 2005 and simply has not been reconsidered since. Fourth, if you and your doctor do decide to change something, ask about the taper, that slow, safe step down I described. A careful doctor will bring you off gradually over several weeks and keep an eye on you the entire time. And fifth, start keeping track now, before the appointment. Keep it simple. Every morning, write down your blood pressure reading, your energy on a scale of 1 to 10, and, if you check it, your fasting blood sugar. 3 or 4 weeks of your own numbers turns a vague, "I have just been tired," into hard data your doctor can actually act on. That one sheet of paper can change the whole conversation. Lorraine, the woman running on half a tank, her cardiologist eventually did move her off the atenolol, slowly, over about 8 weeks, onto a combination without it. And I want to be honest about how that went, because these stories get oversold all the time. She did not wake up 20 years younger. But within a few months, her blood sugar had settled back down, she had dropped a few pounds she had not been trying to lose, and she had started taking her evening walks again. She told me she felt like herself for the first time in a long while. Her blood pressure stayed right where it needed to be, a touch steadier even. People assume that leaving a blood pressure drug means losing control of the number. For the right person, it simply does not. That is the whole point of today. The medication you are on should still fit the person you are now, not just the person you were when it was first prescribed. None of this is me telling you to quit anything on your own. It is me telling you that you are allowed to ask whether your prescription has kept up. Medicine moves. Sometimes the pad does not move with it. If this helped you see your own medicine cabinet a little more clearly, do the small things that keep this channel going. Subscribe, give the video a like, and leave a comment. And if someone you love is on a blood pressure pill and dragging through their days, send this to them today. One honest conversation with a doctor, armed with the right questions, can change how the next 10 years feel. I'm Dr. John Myers. Take good care of yourself, and I'll see you soon.